Hi everyone, I'm Phoebe and I'm one of the volunteers for the Cardiff support group. As a student myself, I always really enjoy hearing about new scientific research, and I especially like hearing about research in endometriosis as it's a topic that's very close to my heart. And I find it inspiring to sort of help me want to continue raising awareness and meeting all of you. So today we are lucky enough to be joined by Dr. Christian Becker, who is a consultant gynecologist as well as an associate professor and the co-director of the Care Centre in Oxford. As Jack mentioned, it's a centre of expertise in clinical care and research for endometriosis. Um, Christian's going to be talking to us about the research that they do, as well as how COVID-19 has affected this research. Like Jack said, feel free to use the Q&A button at the bottom of your screen to send in questions, and Jack will read them out at the end. So thank you, and I'll pass over to Christian.
Good, thanks, Phoebe. So I'm gonna.
Second, there we go.
Yeah, hi everybody. I'm trying to share my screen now. Let's see how that works. Share. Here we go. If I do this in a full, let's see what happens actually. Oh, that works. Oh, good, perfect. Can you see that?
Yes.
Good, excellent. Right. So I was given this title, and so how does COVID-19 affect or has affected the work in our endometriosis care center? I could, or the other question could be, what work have you done since COVID? And that would be a very short talk because COVID-19 has affected us tremendously, as similar, probably all of you. And I'll come to that a little bit more in detail, which, we can discuss then as well, and maybe exchange experiences as well. What I wanted to do is, oops, if it works, let's see. Yeah, there you go. Just to show you that, so the Endometriosis Care Center is a collaboration, basically, of the University of Oxford. So I'm an academic officially, or half academic, half clinician. So I'm employed by the University of Oxford and do 50% work there and 50% endometriosis clinic. I lead the endometriosis, the BSGE Center in Oxford clinically as well, and I'm the co-director on the university side together with Professor Krina Zondervan, who now is also our head of department within the department in the university. So the nice thing about this is that, in a way, fortunately, we're under one big roof at the John Radcliffe Hospital in Oxford. In a way, not because it's a very old building, so it has its advantages and disadvantages, but in order to do research, it's very good because if you want to do translational or clinical research, it's very convenient because you have the patients on one level and then you have the research floor on a different level. So that works actually quite well. So before I tell you about what effect COVID has had on us in the endometriosis care center, I just want to give you a rough idea of what we normally do. First of all, it's very clear that the center is not working without a huge team effort, and as you can imagine, the nurses are playing a big role in this. We have actually now 3 part-time endometriosis nurses as well, because we're a relatively large center, as you'll see in a minute. There's lots of surgeons involved. Surgeons does not necessarily mean that everybody's doing surgery for patients with endometriosis, but we have a special endometriosis theater list as well for severe cases and maybe not so severe cases as well. We're fertility specialists. My background actually is reproductive medicine, so I have a special interest in that. But we try to be as broad as possible. On the bottom right, you see my colleague actually in the dark blue sweater. That's Krina Zondervan, with who I co-direct the endometriosis center. So it is what we're trying to do is amalgamate the clinical expertise and the research that we have in the University of Oxford, and we believe it works fairly well. So clinically, as I said, we are one of the BSGE specialist centers. I do not know how much everybody knows who's listening to this. So the NICE guidelines suggest that women should have access to these specialized centers. And that is because, especially women who have stage 3 or 4 disease and who may need surgical treatment, they ideally should be treated in centers who have a lot of surgical expertise in that, because some of these operations, again, I'm not saying that everybody needs an operation, but those operations can be quite tricky. And, with surgery, it is the case that the more you do, usually the better you are. And that's why the BSGE, the British Society for Gynae-Endoscopy, which is supported by the Royal College, are trying to get everybody in specialized centers. And there's, I think at the moment, about 49 of them. I may be wrong with the number recently. There are full centers, and then there's a few aspiring centers at the moment as well. So you see here Oxford, of course, I must say, in the center of gravity, often not, but you see here we have a relatively large radius with people coming from all over the area, but also out of area throughout the country as well, are coming to us. And these are slightly older numbers. Actually, I need to update this. These are the surgery numbers for different years in the different endometriosis centers. You can see, and this has changed slightly. So this is from 2015, the latest data. But as you see on the bottom there, back then we were definitely the largest center. There's, it hasn't changed very much. We are definitely in the probably top 3 or 4 number-wise. Does not necessarily mean that because you do a lot, you're necessarily the best, but we obviously strive to be as good as possible to our patients as well. All right. So the Endometriosis CaRe Center, so CaRe stands for Care and Research, is, as I said, housed in the John Wycliffe Hospital in the Nuffield Department of Women's and Reproductive Health. There we do quite a few things which I wanted to show you. So one large thing that what we do is teaching. And as you know, a lot of women are suffering for a very long time with symptoms. Often these symptoms are not really recognized either from the patients themselves or from the medical professionals. And what we are aiming to do is educate both lay people, but also GPs, who are usually the first line of defense there, to really think about endometriosis as a possibility for the patient's symptom. And therefore, again, in normal times, we go out to GP practices, give seminars. We sometimes have centralized seminars as well. But COVID makes this very, very difficult, although it's starting up again at the moment. Another big thing, and that's a important thing also from a university perspective, is outreach. So actually you go out, you go to science festivals, you speak to people out there on the street, explain to them what is endometriosis, go to schools, and that is what we're trying to do here. This is a picture of a podcast. So one of our PhD students who's very interested in these outreach approaches. She's done a few videos, quite professionally, I must say, but she's also had a scholarship for the Royal Institute of Science, and went there for, I think, 3 months, and then learned how to really do this professionally. So she did a podcast with Krina Zondervan and I, which is freely available. So if you want to look and listen to this on the website, it's freely available with the link there. Yeah. Then, what our students do, and we very strongly encourage that, to really go, as I said, out also to schools here. You see that on the left, the four of them. I think this is where they went to a primary school to explain to them what DNA means, because some of our studies are genetic studies. And as you can see here, this is a double helix that they're trying to make out of gummy bears. So make it really easy for them to, for children also to understand what this is all about. On the right, you see that we are, not infrequently contacted by the press, either to give a statement about some new press release from someone else, or here, this is this particular picture on the right is by The Guardian. I think this was from actually quite time ago, also from 2015 or so, which was an interesting story because I think one of the editors from the Australian bureau wanted to write a piece on endometriosis, and then just locally she asked around in her office, has anyone heard of endometriosis? And then you suddenly had other women put up their hands and say, yeah, I have it. She was absolutely amazed how frequent and how prevalent it was. And then she made a big thing out of this. And there was then a huge story that came out frontline of the Guardian, and also actually online. It was the front page, at least for about an hour, and then I think it was the Labour Party conference on that day, so we were pushed away. But at least it was something that we could be proud of as well, to really get the message across and out there. And they frequently do that, not only the Guardian, but other press organs as well. So now we're coming to the research that we're doing, and it's fairly widely spread out. Let me talk about a few of the projects that we're doing. The upper bit here is the Worth Effect project, which stands for Endometriosis Phenome and Biobanking Harmonization Project. It's a bit of a mouthful. And this came about because we are interested in biomarkers. As you know, there's no biomarker out there that will predict whether someone has endometriosis or not. Some people say, well, maybe a CA125 is something that you read in old books, but if you actually look at the evidence, unfortunately, there's nothing out there. So I had a PhD student a couple of years ago, well, actually quite a few years ago now, who was looking at a particular marker, and I said, well, in order to do your job right, you have to really see what's out there first. So she wrote she looked at all the evidence that was out there and wrote something called a systematic review, where you really systematically look at all the papers out there. And what we did find then was, again, that there were lots of research studies done on various molecules and proteins, and you have it, but none of them were clinically useful, because usually the studies were way too small. The population was too heterogeneous, so sometimes they had men as controls. And the other thing that was very important to know was that the way the data was collected and the samples from patients that were collected, blood samples, for example, or urine or whatever it was, the way it was processed was absolutely non-standardized. So some people spun it, at 4 degrees, some at freezing, some at very quickly, very, very smallly, very, very, very slowly. And if you have a little bit of knowledge what's happening in the lab, it's very important really to have a standard, so you can actually compare not apples with oranges, but similar things. And that's how this Worth Effect came about. Worth is the World Endometriosis Research Foundation, so under their umbrella, we worked on this. And this was a quite large collaboration really throughout the world, where led primarily by Oxford, by Queen Zondervan, and Harvard, Stacy Mismer, and I helped out a little bit as well. And then with experts from many different countries, where we really looked at the evidence of how to best collect data from patients, how to best collect and store samples in a way. And then we published. So this was the larger group that we've had, and then we published these protocols in as open access, so anyone who's interested in endometriosis research can use them, and they are updated frequently as well if new evidence comes in. So therefore, if patients are included in a study in, let's say, San Francisco versus Oxford versus Edinburgh versus China somewhere, if the center uses those protocols, we can be quite certain that the data and the samples can be compared, and therefore you're much more likely able to have large-scale studies, which was really important. Because when we did our systematic reviews and we looked at all the other studies that were out there, they were usually small, 50 patients, 100 patients maximum or so. And then, if people find something, so they're looking at a molecule and see whether that's, for example, more expressed in someone versus the controls. First of all, if you don't find a difference, then it's very difficult to publish. That's always a problem. But if you see a difference, then you may be able to publish it in some scientific journal. And then at the end of each of these papers, everybody writes, oh, this is fantastic news and this is very promising, but we have to confirm this in larger studies. And then no one does those studies because you didn't have the amount of not enough samples there that to do that that you could compare. And the EFFECT project really helps with that. And now I think there's over 30, I think almost 40 different centers around the world who take part in this. Oxford is obviously one of them, but they're all over the world. In the UK, there's another one or two as well, and we do collaborate very nicely on various research projects. So then the other thing that we're doing is, and actually that relies on those worth effect protocols, is Fenox. That's the study that we use where we collect both clinical data. There's a long questionnaire that patients are asked to fill out before they undergo planned surgery, and then also biological samples, either just before or during surgery, which for endometriosis would be usually blood, urine, saliva, and then during the operation we take some peritoneal fluid, so fluid from the abdominal cavity, endometriotic tissue, fat tissue if they're happy, and also a biopsy from the uterine lining. Obviously, patients are consented and they can opt in or out for particular things. And we do this because we want to have a relatively large sample collection to do these large-scale studies. Because, as you probably know, and I'll show you a few slides later, endometriosis is really a heterogeneous condition, so it's probably not one thing. It's very probably different subgroups, which we just haven't found out about yet sufficiently to separate that. So this is, again, this Fenox study, which is going on. This built on the previous study, which was called Endox. Fenox is also including fibroids, because there's also certain interest in uterine fibroids here in Oxford as well. So we're collecting not only endometriotic tissue, but also tissue fibroids from women undergoing fibroid removal, for example. So we already have quite a few participants. So Endox was 799, and we are still doing follow-up questionnaires for these women. And then it was followed by Fenox, that's still going on at the moment. So as I said earlier, it is very important to have collaborations going on. These are, the different centers or some of the different centers we're working on or working with around the world, within the UK as well. And I must say this works quite well. We're very grateful to all the patients who take part in our studies, and that's not only us, that's everybody who does these studies. It is amazing how motivated women are who are suffering from endometriosis-associated symptoms, and it is very, very good to see how helpful they are in the research as well. One of the things that we do in Oxford is target discovery, and this is working together with a few companies. I don't know if that's on, yeah, here we go. It's on the next slide. So we have a very large grant with Bayer. We also worked together with other companies, Roche, Volition, and mDNA Life Sciences as well. Partially, we just supply some of the samples that they need to do biomarker studies themselves. Sometimes, for example, with Bayer, we actually look for, so we have an active collaboration where we look for new possible targets in endometriotic tissue, for example, where that may be in the future a target that could be attacked therapeutically, something that's specific ideally for endometriosis, and that could be then attacked, and not only the usual hormonal approach that everybody is using at the moment. And the reason why I'm saying this is because this is pictures from a paper that we published fairly recently. This just to show you, the different, the differences between endometriosis, and we still treat these patients, very similarly, if not exactly the same, in a lot of cases. So here, I don't know if you can see my cursor here, but you see these very small in panel A, these very small lesions. Sorry, it's a bit small probably for you to see. Whereas on panel B, this is what we would call stage 4 endometriosis, where you see this pink thing here in the middle, that's the uterus. The two white bits are the ovaries, and they're stuck together in the middle, and we would call that kissing ovaries just because they're touching each other. And then the pouch of Douglas, which is here, this thing on the left-hand side, which is, this whole cavity behind the uterus, is totally obliterated. So, it's all scarring here that you can see. And again, this is, treated very similarly, but probably has a different background, or there are different factors that play a role. In panel D, you see an ovary, and here I'm poking a hole into it, and you can see the kind of brownish stuff coming out, which is the reason why it is also called a chocolate cyst, which reminds some people of warm chocolate. I think that's arguable, but anyway. And here down here on panel E, that's a typical endometriosis deep nodule, and it's quite interesting. And there's I'm always asked. I have a lot of patients coming through the door and say, first, or one of the earliest questions is, do you excise? Because there's a lot of discussion, I think, out in the different fora about ablation versus excision. So I just finished an operating list today, and I would, if we look at the actual evidence, there's not very much out there to say that excision is much better than ablation, but I think it's the matter of finding the right indication. So here you would say, this looks, maybe a few lesions, the white arrows on panel E look very superficial, and some people would just burn them, but then you would possibly miss that white bit in the middle, which is encircled by the black arrows, which is actually, was a 2 or 3 centimeter nodule that is growing into the bladder here. So there is a point for excision, and there's also a point for very superficial endometriosis to be ablated. I think it's just a matter of finding the right balance there. So one of the goals that we have, and that's not only Oxford, that's again I think internationally in the larger centers that people are aiming for, is to have a more stratified and precision medicine. So again, avoid throwing everything in the same bucket and treating it exactly the same. You need to see if you can find subgroups of the disease of endometriosis, and maybe therefore have a much more personalized, individualized treatment approach. And that's why you need to have large numbers of patients, because they all differ a little bit. Some are different parts of the cycle. Some have very few pieces of disease, lesions of endometriosis. Some have a significant endometriosis. Some have had children. Some haven't had children. All these type of things you have to put together in order to, and you have to, and then eventually divide them and see whether there are differences between these different subgroups. And then this friend here hit, COVID, and that has really caused significant problems, not only for us, but I think for everybody, and especially for a lot of the people who are probably listening to me tonight. Everything was shut down. So I don't know exactly when it was, probably sometime early March. We were told, we cannot do any clinics anymore. We cannot do any elective surgery anymore. So actually today I operated on a lady who was canceled, I think on the Monday or Tuesday when actually things were shut down. I don't know what day it was. So basically she was one of the first women who were cancelled, and now where we well, not quite, but 8 months later, and finally we could do her case. So it has had a significant impact on this. In Oxford, because we hadn't been hit so badly with real sick COVID patients, it hasn't been as bad as some of the centers in London or in Birmingham, for example. But still, especially in the beginning when nobody really knew which way this was going, everything was shut down. And we as doctors, we were sitting at home, while doing our admin stuff. But at some point we thought, well, can we do some work? And then eventually, when people started to learn that things are probably not progressing much more, and I guess the lockdown started to kick in, then we started to do a lot of clinics again, telemed clinics mostly. And for the last, I don't know, probably month and a half or so, maybe 2, in Oxford, we've had face-to-face clinics again, which I must say are preferable for me, because I like to see my patients. Sometimes it's much easier to for patients to just call, and especially if any one of you had to come to Oxford to our hospital, parking is a nightmare. So it's quite helpful for some of these for some of the patients just to be able to call in. So we probably at the moment have a mix, and I'm sure this will be something that we will have in the future as well. This is Katie Vincent. I think she's also giving a talk, Phoebe, correct me if I'm wrong, in the future as part of this forum. I think she was saying something in about a month's time or so. And Katie is, also associate professor working in the department with us. She is very much interested in pelvic pain, and not only endometriosis associated pelvic pain, but pelvic pain as a whole. And I think if you get a chance, you should listen to her, because it's very interesting what she has to say. She's very good on a research perspective as well, and clinically she sees a lot of pelvic pain patients with her colleagues as well. Now, what she did, and that was I think great of her in the early days of COVID, because we had seen a lot of questions from women who had been affected by this, by the fact that we couldn't really treat them. We tried to give them some general advice for during the COVID time. So because the GP surgeries had closed, what can I do if my pain is getting worse? People were desperate, and therefore on our website, and still there, is a lot of general advice of what can you do with various hormones. If I have breakthrough bleeding, can I double up my dose, and other things as well. So I think this was actually, I believe, quite helpful. I'm very happy to listen to get feedback from you if you had a look at it. But Katie said that she had a lot of positive feedback from patients in our region. And then the other thing that she did, and I helped out with this, because as you probably hear, my background is German. There was a large online survey just to see what impact COVID had on the physical and mental health of people with endometriosis, which I'm sure you can tell me long stories about today. This was sent out, I think, if I remember correctly, through Endometriosis UK. And I think Katie will talk about the data when she talks to you in a few weeks' time. She gave me a few slides just to give you an idea, but obviously this hasn't been published yet, and they're trying to publish this as well. So this is hot off the press, or not even in the press yet. So this is just to give you an idea. So they were, most of the most of the questionnaires were sent out electronically, obviously within Europe, so 67%. North America, we had a lot of feedback as well, even Latin America, mostly Brazil, and then some in Oceania, so there, and Africa as well, but you can see the numbers were very, very small. So this questionnaire, which was, I don't know how many questions there was anymore, but quite a few questions again, was translated then into Spanish, into French, definitely into German, and I think maybe other languages as well. So at the moment, they're just going through the series. You see the distribution of where we get the responses for. As you can see, the UK obviously was the strongest one with the local support here. And here are the different answers. So it must have been Portuguese, obviously, as well. Otherwise, we wouldn't have had Brazil and Portugal in there, and some of the other countries as well. So I think this is quite interesting. And you'll see the results of the study, hopefully, when Katie speaks to you. Just one thing that she was saying here of interest. So to give you an idea, these are global results, and it'd be interesting to see whether there are differences in different countries with different healthcare systems. But one of the questions was, have you worked that your endometriosis makes you more vulnerable to COVID? And the majority of women answered yes to that. So I think I'm coming to the end of my talk. Again, Endometriosis CaRe is one of the BSGA centers in the UK. We strive to ideally give our patients the best treatment and management as possible, and combine it also with good research to move the field forward. It is a very slow process, but we really need help from everybody. The volunteers. I can only say, if I get emails after this, we can only accept patients who are having surgery in Oxford. So unfortunately, at the moment, we cannot just have patients come through the door and say, here, I'm very happy to donate my blood or saliva. So people have to be planned to have surgery in Oxford. I'm not saying that we're doing surgery any better than anyone else, or worse, hopefully not, but that's how the ethics approval works at the moment in Oxford. Whether that changes in the future, I'm not sure. Good, so I'll stop sharing my screen, and then I'm very happy to answer questions if you want to.
Thank you, Christian. Hang on, let me just make some changes. 1 second. Okay, Christian, thank you so much. It was very interesting to hear, as ever, about your research, and to hear how you've been impacted at the centre by COVID. We have quite a few questions. Some have been sent in via email, and we have a few in the Q&A function on Zoom as well. For the sake of time, I don't think we're going to be able to have people asking them to you individually, so I will ask them if that's okay. But, if you haven't already submitted your question via the Q&A, please do so. We'll get through as many as we can. One that came in via email asked, how have you, Christian, coped during the pandemic? I assume it means professionally, not personally, but please.
Yeah. So, personally, I must say, because I was able to go to the hospital, it was okay for me, because I didn't have to stay in the house, and I just, I'm amazed by how people had to stay in small apartments and so on. I mean, we were very lucky because we have a little garden in the back, and I just don't understand how people were able to cope in small flats with maybe 2 or 3 children and so on. So just amazing. Professionally, personally here, so what happened was, obviously, we're gynecologists and obstetricians, at least by training, and babies keep coming, and the trust was very worried that obstetricians would go off sick. So what they did was they retrained the gynecologists. So we're very specialized nowadays to do obstetrics again. And so after, I think, 11 years, I delivered my first baby again. I must say nothing's changed, so the anatomy is exactly the same. But that's what happened. But for me personally, it was only for, I think, 3 weeks. Some of my colleagues did this longer, but because of various logistical reasons, I went back to gynae and had to do a lot of on-calls there, but it was fine.
Brilliant, thank you very much. And Jodie Hughes asks, she says, I'm just starting a PhD in endometriosis care in different groups. Is there any way that I can get in touch with you to chat about research?
Absolutely. If I don't get 100 emails tomorrow, then I'm very happy, but very happy to. Just send me an email. Please, I don't mind being reminded again, because I do get a lot of emails, unfortunately, but very happy to answer them. Eventually I will. It's just sometimes it's busy and then it's difficult, but very happy to email or even chat if we find some time. That's absolutely fine. Thank you.
And a few questions about this, so I'll ask it now because I think we had 4 questions. In the context of the pandemic, on average, how long are referrals taking? How long is it taking people to be seen by specialists?
Yeah, so in Oxford specifically, we are currently closed for external referrals. That is partially because COVID, but I think more likely because locally we were just overwhelmed with referrals in the first place, and that was, I think, even before COVID. And then the trust said, we got to make it, stop this, and they just stopped accepting patients from the outside. I'm not sure whether that was a very smart move, because obviously the trust was hoping that then patients would go to other hospitals in the area. I think a lot of GPs are still sitting on their patients, and once we open up, which realistically shouldn't be too bad because we've worked down the mountain a little bit, it will be open hopefully relatively soon, and then it will be a similar situation. We're trying to recruit more staff, so hopefully we'll be more efficient in the future. But at the moment, obviously there's the 18-week goal from referral until diagnosis or treatment has been done. We try to in the future, ideally talk to patients within 6 weeks after referral. Also purely because the trust is very interested in that that leaves enough time then afterwards to do the treatment. Because if you see patients after 15 weeks, you only have 3 weeks to get them into the treatment arm, which is usually not possible. And then, the trust gets fined for this, etc. So that's the plan, at least in the future.
Brilliant.
But I think the easy answer is way too long.
Thank you. Yeah, no, that does seem to be reflected by the people that we've spoken to. From Leanne Haxwell, or Hawkswell, sorry if I put your name wrong, Leanne. Any tips for convincing a GP to refer to a specialist centre over general gynaecologist? So to refer to a specialist centre rather than a general gynaecologist.
Yeah, difficult to tell. I mean, if you look at the NICE website, the guidelines for endometriosis, I don't know exactly what the wording is, but I think it says that patients should be referred to a specialist center. Now, whether it has to be a secondary or tertiary center like ours, which is a bit of a combination, I'm not certain, but at least you should have access to a secondary center, and they have to do it. I mean, there's no question around it. What sometimes happens here in Oxford is that patients either, they email me and please don't, because otherwise my emails is just overflowing, but they contact our endometriosis secretary and say, look, what can we do about this? In the end, we do need a referral, because otherwise the hospital cannot charge the NHS, I guess, for this. People unfortunately have to go sometimes through private as well. I really don't want anyone to think that they should go through private in order to get quicker into the NHS. I do see private patients, but I don't think that's a good way. So I would really like to spend my time to improve the NHS process than seeing private patients and making them pay a lot of money. So
yeah, thank you. No, that's great. We've had a sudden sort of influx in questions, so I'm going to try and move through a few more. You've answered, I've got one about the current process for seeing new patients, but you've answered that, so I won't ask you. We had a question via email from someone who is a nurse and was talking about her experience of coping with having to wait for an unknown amount of time now for surgery. And she asked a question that I think lots of people will resonate with, which is, when is endometriosis going to get the recognition of other surgeries? Do you have any thoughts on that?
Recognition?
I think it means over being, having the being able to take place during the pandemic. So some surgeries are allowed to continue, and endometriosis surgery has been cancelled. I think.
Well, so I can only speak for Oxford because I don't know how this. I think UCH, because I know some of the people there, they're also doing surgery again. I don't know to what extent, but in the end, what often happens is that the trusts are going by also, the waiting list, etc. So they try to get rid of that. Now, it's very, very difficult, and obviously I need to be careful what I say as well. But personally, I would argue that women who are sometimes in excruciating pain, should have a priority. And I think if you have a good doctor who knows you, or there's a connection there, he or she will try everything ideally to move things forward. It's tricky because there's so many patients, unfortunately, who are in this similar situation. I mean, the thing is, obviously surgery is a treatment, and I think what we have to think about as well is, and especially during these times when surgery is not so much available, is if there's any way in optimizing the conservative treatment as well. Unfortunately, this still means hormones. Now, if someone is trying to become pregnant, obviously that's not an option really. But I think there are, in some cases, still options to optimize that to maybe avoid surgery altogether. Because, well, I would argue nobody really wants to do surgery if they can avoid it. But if we can improve that, then we can probably reduce the number of surgeries that we need to do as well. Because surgery, as I said, I was doing a whole list today, but surgery is doable, and we do this very often, but it's not without risks, and it's also not always the solution to everything. You can create more problems with that. Obviously, the hormonal approach has all the side effects as well, so it's tricky.
Yeah, thank you. It's a very difficult question to answer, but I think it's one that everyone's feeling at the moment. I'm going to try and do a few quick ones because I can see there's quite a few that have come in. Have you done any research into adenomyosis?
We in Oxford have not directly. We do see patients with adenomyosis, but we don't have an adenomyosis project that's going on at the moment. We've been talking about this for a long time, but so far not. I think it's absolutely necessary, and we know even less about adenomyosis than we know about endometriosis, I must say. So it's absolutely necessary, but we don't.
Thank you. I have a question which seems to be related to something you previously said. It says, I was diagnosed with endo during lockdown on the waiting list. I would like to learn more about Dr. Becker's experience of managing endometriosis naturally without hormones ahead of a long waiting list of surgery.
Yeah. So I'm chairing the ESHRE guidelines for the management of endometriosis. So I think we had 2 guidelines out already. The last one was from 2013, and we're currently going through the new evidence that is available. So if you think about kind of non-medical approaches, for example, such as diet as a possibility, or various other things as well. If you really look at the pure evidence, as in studies showing 500 patients treated this way and 500 that way, there's nothing out there. So that is unfortunately clear. Anecdotally, from my practice, and if you talk to other people, we know that some patients benefit from changes in their diet. And to be fair, I'm not a specialist in that. I know that if people avoid some people, if they avoid gluten or dairy or certain sugars or so, they benefit from it. It's not a thing that happens overnight. So it's not like have a headache, paracetamol, and in an hour it's better. But so it's a long-term or mid-term thing. But that's it's worth a try if you can. The other thing that we do, and Katie Vincent will be probably better to answer that at some point. Endometriosis or endometriosis-associated pain is probably much more complex than just the endometriosis and just cutting out the disease or just suppressing it with hormones. So what we often see is a significant musculoskeletal component to the pain as well. So physiotherapists who are specialized on pelvic floor spasms, etc., they may help as well. Cognitive behavioral therapy, so we offer this here in our pelvic pain clinic, is helpful. So again, that there's no good evidence for this from a paper's perspective, but there's increasingly so. And again, Katie will be able to tell you more about this in detail.
Thank you very much. What's the best way to keep finding out the most up-to-date Oxford research, or is it just to keep checking the website?
Yeah, they keep checking the website, or which probably shows the latest papers. I mean, if you want to see the results, if you want to see what studies are going on, probably the website. I mean, as you can imagine, the website is not always perfectly updated, but we actually have a data manager as part of the team, and he's quite savvy with all these IT things. So he tries to keep things pretty much accurate and actual.
Brilliant, thank you. I've got quite a slightly deeper question, but if we can try and keep the answers fairly short, we've still got a few to get through. What are the long-term impacts on endometriosis, patients and treatment following COVID-19, apart from the backlog of surgeries?
We do not know, because I mean, it's still a relatively early disease, if you wish, the COVID situation. Again, Katie will probably show, I would assume, I have not seen the data, but it will probably show you that it will have had an impact on the mental well-being. I mean, I don't think you need to have endometriosis to be affected by COVID, but I can imagine if you also have if you have significant symptoms due to endometriosis, and you have to deal with all the COVID issues that we all had to deal with, that probably did not help and probably made things worse. Whether the effects on accessibility to doctors had a negative effect, it will take years to find that out. The thing with endometriosis is that there's no good data to show progression of disease. So there were studies in the past where they did a laparoscopy, then treated patients with either placebo or with the drug. In other studies, they did surgery at the initial laparoscopy, or sham surgery, so just a diagnostic laparoscopy, and then they did 6-12 months later a second laparoscopy to see what effect was there on the disease. And in those women who've had placebo in the drug studies, or just a diagnostic laparoscopy the first time, about a third of patients had more disease, about a third of patients had the same amount of disease, and a third of patients had less disease as well. I would not say, let's wait for your endometriosis to go away, because I don't think that will be the case. And so it's also much more complex, because less disease may just mean smaller lesions, but it does not mean that that means less pain or less symptoms. But whether in the future we'll see that these effects on the clinic will have had, will increase, the infertility, for example, or pain scores, or so. I don't know. It will take years before we know.
Yeah, exactly. Yeah, but thank you. You did answer that really well, considering it will take us such a long time to know. I'm just going to ask you 3 more, and I'm so sorry to anyone that's asked questions that we've not been able to get to. As always, we just don't have enough time. I will ask 3 more, and I'll try to pick ones that other people have asked as well. So a fairly quick one from Ruth Ratcliffe, hopefully. Is bowel endometriosis surgery allowed to go ahead during the pandemic? So bowel surgery.
For us, yes. I don't know how different centers think about this. This is a local decision by the trust,
Yes.
depending on their local things. But yeah, with us, yeah.
Perfect. Thank you very much. What is the typical patient journey for someone with endo from referral? If you could summarize it.
Well, I think the biggest step is the referral, I think, and I think we agree on that. In Oxford, it would mean that, and we were just trying to change the algorithm a little bit. What we'll probably do is to have a telemed clinic first, to kind of assess what needs to be done, whether we need to organize an ultrasound scan if it hasn't been done through the GP, what the symptoms are. Is it more fertility that the patient is worried about? Is it more the pain? Can we optimize medical treatment, or is surgery necessary? So that would be ideally the first thing, and that ideally would like to do this within the first 6 weeks. And then they will have, maybe ultrasound scan or MRI, depending on what imaging it is. And then we will do ideally a in-person, face-to-face consultation, where we examine the patients where necessary, and then decide what to do, whether surgery is necessary or not. During that first consultation, the telemed one, we may already give recommendations as well.
Brilliant, thank you very much. We have 2 questions from Esmeralda. I don't know if you can read them, Christian, on your view. If you can't, I can read. I'm going to pick one, which is the first one. What does NICE say about referral in cases of recurrence or suspicion of recurrence of excised endometriosis that was previously stage 3 to 4, which may not be that severe yet, but given the history, may well progress rapidly? Now, I appreciate you might not know the guidance that well, but do you have any comments?
I don't know exactly what NICE says, but I think overall, I think the statement is that women should have access to to us, as in the specialist, if you want to call us that. Whether, again, whether a stage 3 or 4 endometriosis needs more urgent treatment than stage 1 or 2, I'm not sure. I think all patients need to be treated equally urgently. However, obviously, if there's bowel involvement, there's always the risk of that the bowel is it's growing deeper into the bowel, or the bowel is stenosed, and therefore it's more difficult to go to the toilet. The other, I think, urgent thing that needs to be done is if patients have involvement of the ureters, because which are the connections between the kidneys and the bladder, because that if it presses on that, or if the scarring closes the ureter, then you may have a problem with the kidney long term. So that's an urgent thing, but that's a rare thing, to be fair. I mean, most people don't have that.
Brilliant, thank you, Christian. And I'm going to ask one final question, which we missed somehow. It was one of the earlier ones. Can people live with endo, managing it without surgery?
Absolutely. No, I think that's a very good question as well. So as long as they can manage the symptoms, and that means not only the pain, but also, that if they are trying to become pregnant, they get pregnant, then there's no reason why you need to intervene medically or surgically, because again, we don't know whether it progresses. It depends probably a little bit on the disease. So if you have recurrent endometriosis cyst, I probably would intervene and say, well, maybe let's put you on the pill if you're not trying to become pregnant, to reduce the risk of cyst production. Whether, I guess you could push that that question also in the direction of, are we worried about cancer? So I think the easy answer is endometriosis is not a precancerous condition. I think that's clear. There are certain certain cancers that are more common in women who have endometriosis than those who don't. Ovarian cancer is one of them, which is, I guess, the one that worries most women. That risk, and we just looked at the data, and there may be, actually, I think this available to everybody. It's a free access in Human Reproduction Update. So it may have come out already this week or last week, or it will come out in the next very few weeks. A systematic review on endometriosis and cancer. So you look that up. It's it's quite scientific medically, but you get an idea that yes, there is a percentage increase. Don't ask me what the numbers are. I apologize, because it's too many different cancers they looked at. But and that's statistically significant, but whether that is clinically significant is another question. So if the overall risk of developing ovarian cancer is, I don't know, 1 in, let's say, 40 or so, I don't know exactly what the numbers are. With endometriosis, it may be 1 in, I don't know, 35 or so, something like that. Don't quote me on those numbers. But yeah, so yes, it's it's a rare condition, or relatively rare condition anyway. But if with endometriosis, it may be slightly more common, but not very much, to be fair. So again, just because someone has endometriosis, just quote unquote, just because someone has endometriosis, it does not mean we have to take endometriosis. We have to take the endometriosis out because of the risk of cancer.
Brilliant. Christian, thank you very much. Oh yeah, I've just seen a question from Sunaina asking you if we'll be sharing it online. I believe so. We've recorded it, Sunaina, so we will endeavour to share it. Okay, I'd like to say a massive thank you to Dr. Christian Becker. I really appreciate you giving us your time today.
That's all right.
It's been really, really interesting hearing you talk. And thank you for answering everyone's questions.